Okay, I mean, my watch says it's 1:30 p.m. I really welcome all of you to this session. I'm very glad to see all these people. We are missing this opportunity to stay together. I guess most of us, we will get back home with the COVID, but it doesn't matter. The important is that we enjoy this time. Don't test it unless you feel too sick, and go to work, because that's the problem. You test positive, then you stay at home. It would be a great program for me on Monday. So I will test myself on Monday. This is a sponsored session by Shockwave. It's dedicated to conquer the calcium with intravascular lithotripsy. It's based on the review of cases. And of course, it's an interactive session. So our moderator, Antoinette Neylon, don't you will explain how it works?
So we've all got our phones, so we're so attached to them now. So use the app to send your questions. We have the French OCT guru, Nicolas Amabile, who's going to be answering all your questions on any imaging and calcification. There are mics in the room, so don't hesitate. Get up and talk to us, please. So it's really based around cases and clinical experience, so really practical stuff. So really don't be shy. Ask any questions.
Okay, these are the objectives. You are here because you want to review with us the latest data from the DISRUPT CAD clinical evidence supporting the use of IVL across the different calcium morphologies. This is one of the main cores of our meeting today: what is eccentric, what is nodular, what is concentric, how the device works in these different situations, to appraise the most recent one-year OCT-pooled analysis of the DISRUPT CAD 3 and 4 studies, and to evaluate the outcomes of intravascular lithotripsy use in females. That we know it's a high risk and difficult to deal with in any aspect of our lives. So I will call Professor James Spratt. Please, James, do the favor to us to come here. And I am opening your presentation for you. That's it.
Great. Thanks, Flavio. And you thought eccentric calcium was controversial. So I'm talking about consistency across calcium morphologies, conflict of interest, fairly obvious on this one. And I think this is an interesting juncture in the management of calcific coronary disease. We're increasingly understanding more and more about it, and at this stage it probably raises as many questions as answers. In some way, concentric calcium is a little easier to understand and easier to manage, but we can't generate arteries according to what we can treat. We have to generate arteries that we actually are faced with on a day-to-day basis. So eccentric and nodular calcium in particular is what I'm going to focus on today. And you can see OCT representations of the schematics that I've shown already. And the question I'm asking or posing to the audience today is the treatment the same between eccentric and nodular calcium as we know it is for concentric calcium? Or do we have a very different mode of treatment and very different methodologies to deal with? So I'd like you to think about this conceptual diagram for a second. So there's this ring of people with this balloon in the middle of the people. And then you've got the same ring of people, only half an arc. Now, if you apply centrifugal force to this kind of concentric force, if you like, you break it in a concentric fashion. But you apply the same force to the eccentric group of people, the balloon expands away from the force. And that's really very similar to what happens in eccentric calcium with balloon-based technologies. Here is an example of the eccentric calcium in schematic form. You can see it in OCT and in IVS format. And when you look at the pooled data from DISRUPT, the DISRUPT series of studies, what you see first of all is it's a common problem. So you can see that up to 50% of calcium comes in the form of eccentric calcium. So it's not something we can ignore, and we can't pretend it's a real-world problem. So what are the mechanical goals of this? Well, ideally, we want to selectively target calcium in a way that engenders concentric stent expansion, because we know that concentric expansion, and particularly MSA, is what determines durable outcomes for our patients. However, if we apply circumferential force, it will, as explained from the schematic, tend to expand the elastic tissue and push away the inelastic tissue. So you get this characteristic tears at the interface between the elastic and the inelastic tissue. Calcium, of course, is inelastic. You apply sufficient force to it and it fractures, but it's a kind of binary event. It fractures or it doesn't fracture. And quite often you get this appearance, as you can see on the left, on the IVUS, where you actually create these multiple tears in elastic tissue, but you actually don't modify the inelastic tissue with balloon-based technologies. And of course, the same is true with stents after you expand. Sometimes you're left with a less than perfect result. You see eccentric calcium on one side and you think, well, I'd like to get that MSA bigger. What I'm going to do is take a big balloon and inflate that big balloon at high pressure. And what happens is you actually, again, extend the elastic tissue and you risk tearing that inelastic tissue and, of course, potentially risk even perforation. And that's because what you're doing is applying compressive force with balloon-based technology only. That's all you're able to apply. This is not a kind of personality-dependent situation. The balloon is only able to apply compressive force. And that's very different to what happens with selective targeting with IVL, where in addition to compressive force, which is very low, 4 atmospheres, you also have shear stress and tensile stress. So you get this kind of crazy paving effect. So you're shattering the calcium across perpendicular as well as parallel lines to where the force is applied. And actually the mechanism of action has been very impressively demonstrated across a range of technologies. Here you've got micro-CT, again, the kind of crazy paving fracturing or the shattering of the calcium. And even here in the cross-sectional pathology image, again, this kind of crazy paving effect. So you're not changing the compliance of calcium. What you're doing is changing the relevance of the calcium to total arterial compliance, because it's total arterial compliance is what you really want to change. So an example of where we stand with this technology at present is that the series of studies to date have demonstrated a very impressive effect on concentric calcium. And what we've been discussing really is threshold of effect. When do you need it, as opposed to how well it works? Below a certain threshold, balloons will shatter concentric calcium pretty well. Above a certain depth of calcium, you really need to target it with specific therapies. And again, the mode of action is demonstrated within these images where you get these fractures around circumferentially, and then those calcific plates move apart to allow the stent to expand so you get the MSA that you want. So if you think about it mechanistically, there are some clear mechanistic advantages of IVL. It's not dependent on hydrostatic force. It selectively targets calcium. It modifies deep wall calcium in a way that's not contact dependent, unlike rotational atherectomy. It doesn't depend on wire bias, and it doesn't matter how big or small the vessel is. So that brings the question, well, if all these mechanistic effects play out, then you should see them play out in the data. There shouldn't be much of a variance between where the arc is and how well the stent expands. And indeed, to date, that seems to be the effect. So across calcium arcs, you get the same consistent stent expansion. You can see 100% across arcs within this kind of pooled data set. And again, the mechanism of action for emphasis is targeting these calcium fractures independent of effects on elastic tissue. So the two important implications are that you result in concentric stent expansion and you don't risk overexpansion in the elastic tissue, as mentioned already. So there's potentially clearly a big safety message there as well. So just concluding on eccentric calcium, I'm not really sure what happened there, but concluding on eccentric calcium, I'll just go through that very quickly again.
Don't say the word concluding because it's go to the...
I know, yeah. Exactly. It's clearly a trigger word. It's my safe word. There's also airport is my other safe word. So without saying the C word, and the C word is obviously very different implications in Ireland, eccentric calcium remains a challenge. Conventional therapies have limitations. There is this mechanistic advantage, and that does seem to translate to procedural advantage as well. So I'm going to touch briefly on nodular calcium. I promise I will talk quickly. This is probably, to my mind, the most difficult part of the calcific morphology to treat, but it's still common and it still results in significant pathology, both from an acute coronary syndrome and from a chronic stent failure perspective. You can see it in OCT and calcium as well. Some of the most interesting bit is that calcific calcium occurs in the background of severe calcium, and that's usually due to torsional stress. You get these plates of calcium, they act as basically a stress model where they can't twist because they've got no compliance left, and you fracture the points in the middle and create these nodules which kind of poke out. And you can see we all know what a right coronary artery looks like, but we sometimes forget how much they move. So if you look at where you should be seeing calcific nodules, it's areas of high torsional stress. So the mid-right coronary artery is a classic area to look for nodular calcium. And actually the proximal LED is also a classic area. You can also see them increase in prevalence at the ostium of coronary vessels as well. And it's also important to remember they don't occur in isolation. They occur in the context of severe calcium. So there's a lot of calcium, you're more likely to see a nodule. It's very unusual to see a nodule in the absence of significant severe calcium. And we're starting to learn more and more about how they behave after we treat them. They either completely deform, and that's about a third of cases. They partially deform, or they don't seem to deform at all. And it's very difficult at the present time where we are to understand imaging-wise up front which way that's going to go. But what you want to see is a fracture within the nodule itself, and that gives you some confidence that you're going to subsequently expand it. And if you look within this data set again, about nearly 80% of cases, you still get concentric expansion. So even though intuitively you might think this is a very difficult subset to treat, you still get very reassuring results. And again, across this data set, you're still seeing equivalent results with calcific nodules in terms of stent expansion versus no calcific nodules, which again is very reassuring. So again, using the C word, you see these visible fractures. Despite that, nodules and the risks of nodules, you get this consistent stent expansion and this deformation, which is a very reassuring finding that you're going to get concentric expansion and a durable result for your patients. So thanks for your attention, and apologies for using the C word.
So we have material for discussion. This is very, very relevant to our session today. First question, do we have questions from our colleagues, Nicolas?
There was one question about calcified nodule, but you addressed it.
Is it appropriate? No, okay.
No.
So, who wants to comment on that? We have Carlo, Nieves. I think this is very important to know how is the efficacy, how effective is this device to deal with these nodular calcifications, which are, of course, a high-risk presentation. You want to comment, Carlo? You have a lot of experience in that.
Thank you. I mean, first of all, it's very reassuring what James showed, that we can achieve on eccentric calcium basically the same multiple fractures that you achieve in concentric calcium. Sometimes it's more difficult to show it. That's because you need to expand it and see it during expansion. Otherwise, there will be some recoil, and that area will look like not being touched. But in reality, the fractures are there. Otherwise, you won't see all this expansion. The question remains: do you always need it? Okay. And I think this is maybe the only question mark that remains. Probably eccentric calcification in very large vessels, the importance will be limited to a situation when you have a bifurcation opposite, and then you don't want to impair flow at the ostium of the branch. In other instances, you may see what happens once you use the balloon.
Okay. Yeah, I think from a conceptual perspective, it's interesting to think not just in terms of how we view imaging OCT IVUS as a still image, but how the vessel performs with a nodule. And if you think of it as a hinge point, an inflexible hinge point, you know, if our engineers are testing stents, what they do is they make one end inflexible and then they move the other end like that. And as with any hinge, if you do that enough, there'll be a fracture at that point. And that explains some of the mechanistic reasons why nodules are so deleterious to long-term outcomes. So it may well be that the acute result distracts us from the long-term durability. That actually the numbers in terms of MSA may not be the whole story here. that modifying the calcium to improve vessel compliance, to improve durability downstream, is probably a better target.
I will make some, let's say, obvious questions, but I think
Keep it
useful.
simple. Yeah.
Yeah. You know, one of the questions we have: does the balloon pressure, 4, 6, 7 atmospheres, play any role on the efficacy of the device, or has nothing to do?
Yeah, so the biggest relationship between IVL and device efficacy is sizing of the balloon. So because it works on such a low level of bioreceptors, you don't need to undersize. If you're not sure if it's a 2.5 or a 3, go for the 3. It's only at 4 atmospheres. The mechanism is not bioreceptor dependent, so you're not looking for high atmospheric pressures. What you're looking for is apposition. If you don't have good preparation of the balloon and you don't have good apposition with the balloon against the surface, you'll lose force as it'll drop off in the fluid between the structures.
Very clear. Point 2, the difference in between the risk of nasty dissections with IVL compared to high pressure balloon.
Yeah, again, another good point, because dissections is a bit of a hobby horse. I'll try and stay off it for now, but we sort of misunderstand what dissections mean. So I think, again, it's goal orientation. What you're trying to do is change overall arterial compliance. You're not trying to change the compliance of calcium. That stays the same before and after treatment, but because it's fractured, it has less effect on overall compliance. So an analogy would be frozen lake. You can go for a walk on a frozen lake because it's basically an uncompliant structure. It's not going to give way. But if you saw lots of patchy ice, you wouldn't step on that because you know you'd go straight through it because the ice would flip. So once you've made those fractures, the impact of the calcium is much less reduced. So, and again, I think probably we're at a point where we don't quite believe that sometimes, and we still go to very large bioreceptors after we've created fractures. Mechanistically, that doesn't make sense, and it probably does increase the risk of severe tears that you saw in the presentation. But I think there's still a bit of a way to go, because what we're doing essentially is using anatomy as a surrogate for physiology, just like we do all the time with MSA and all the rest of it. But here, the surrogate is vessel compliance, and we don't have a good way of measuring that other than implying it from the look of the artery.
Third, last, and I didn't stop, is the risk of rupture compared to high pressure balloons.
Yeah, and again, it's a very good point, because as we've seen from the data so far, the risk of rupture is as close to zero as you can possibly get. So, you know, that's probably one of the decision inflection points at the moment. You know, do I choose it, do I not? And sometimes that question, when you've got a poorly expanded stent, you're taking a big balloon, that's exactly the dynamic you're playing with. Can I take this balloon to high pressure without causing rupture? You're never really having that diagnostic dilemma with intravascular lithotripsy because the risk of rupture is so low. The question is the threshold of treatment. Do I need to do it, is the question, rather than what's the risk of doing it.
Great. We have a question from the floor.
One question. What about the risk of distal embolization? Does it differ between the kinds of calcifications, or there is no risk at all?
Yeah, again, another great question, because if you think of rotational atherectomy, where you're essentially embolizing small materials distally, that's entirely dependent on the mode of action, where you're shaving off calcium. Because the calcium is maintained within an intimal barrier, which is not affected by lithotripsy, the risk of embolization, again, is essentially zero.
Great, very practical points.
Yeah, James,
Nicolas?
we have a question from the chat. Do we need to predilate before delivering the IVL catheter? And how do you size your IVL balloon?
Well, the first thing is IVL is not designed for crossing critical lesions. You know, there still is a role for other calcium modifications, such as rotational atherectomy. You're not going to get the best out of the balloon by shoving it into critical lesions and then complaining if it ruptures. So if it's not delivering, and we can't expect it to be like a particularly low-profile balloon because it's got, you know, sensors in it and all the rest of it, it's not going to do that. So if you need to predilate it, I don't think that's an issue. If you need to rotablate it, again, that's not an issue. In terms of sizing, use imaging, match one-to-one with the vessel.
Okay, I have a question, please. If you have a stent that is not fully deployed because of the calcium behind the stent, so lithotripsy has any role in this, in crushing the calcification behind the stents?
Again, a good question that's commonly asked. It causes upset around the shortwave community because they say it's a relatively contraindicated, it's off-label indication. We've published a fairly large series. I know Carlo has also published a series on that. The bottom line is prepare lesions before you put in stents. But if your colleagues don't do that, you'd never do that, of course. But if your colleagues don't do that, yes, it does work. It works pretty well.
Okay.
And James, if you're using the catheter, do you deliver all the pulses in the catheter every time, or how do you decide when to stop?
Again, another common and great question, pulse management. How do I know how many pulses to give? You know, from a shockwave perspective, one of the complaints they get back is there's only 80 pulses. I need to have more pulses. The next generation device is 120, so I think that'll help to address that. I think you've got to judge it, Antoinette, in terms of the bulk of calcium. Interestingly, from the pooled data at TCT last year, the main limiter in terms of MSA was not the critical calcific bit, but it was the bystander bit that wasn't treated as well. So don't forget that bit. The goal of therapy isn't always luminal treatment. It can be treatment of the calcific bits, which set up that model for stent fracture too.
In the last year, I saw 3 cases of combo, but I couldn't understand why they do a combo, I mean Rota with the shockwave. Can you explain to me the mechanism of imaging? Is imaging before and then you decide it's a combo case with a shock case, or how can you make it?
Yeah, and I think that's where algorithm thinking comes in. That if you think of the limitations of the device being largely deliverability, that if you have a rotational atherectomy case, to my mind, the main mode of action for rotational atherectomy now is failure of device crossing. So if your balloon can't cross, if your imaging catheter can't cross, if there's a lot of calcium, you do rotational atherectomy up front as a way of delivering secondary therapy. That's not to downplay the role of rotational atherectomy, which is still, to my mind, the best device at doing that, but it's also to acknowledge the limitations that it's not going to treat deep wall calcium, and it's not going to, quote, debulk despite what we feel it used to do. We don't use debulking anymore, so it's a way of facilitating secondary therapy. And then once you've done that, you can move on to your IVL stage of the treatment.
Great, thank you, James. Very practical points, very nice questions. I think this is very useful. Now we want to hear Nieves Gonzalo from Madrid, Spain, very expert operator on the calcium field. Thank you, James.
No worries, yeah.
So good afternoon, and thank you very much for the invitation to participate in this session. So we have heard now from James that CAD3 have demonstrated sustained low rates of clinical events at 1 year in patients treated with IVL. So this was reassuring. We also have heard from James how the pooled OCT data from the DISRUPT studies have shown a consistent effect across different arcs of calcium. So in the end, you can achieve good stent expansion with different rates of calcification, and also this very interesting part of the calcium patterns and how it can work also in calcified nodules, as has been shown and explained. So what is interesting, or would be interesting, is trying to understand whether these patterns of morphology, the calcium morphology, can impact clinical outcomes. And actually, there is a specific analysis trying to understand that was performed using the patients from DISRUPT CAD and 3 that had OCT evaluation and 1 year follow-up, a clinical follow-up. And as I mentioned, the objective was really to evaluate whether these findings of OCT following IVL treatment were impacting 1 year clinical outcomes. So the objective was basically analyzing the TLF and also the stent thrombosis depending on the calcium morphology. And I'm sorry to disappoint you, but I'm not going to be presenting a lot of data on this because actually there is a specific presentation, an abstract that was accepted to be presented at the Congress, and it will be presented by Dr. Hondon on Friday. The other very important aspect that I think we still don't have enough data is about the angiographic follow-up of these patients, and also about the intracoronary results of these patients at follow-up. So for this reason, we also try to address this question performing this study in Hospital Clínico San Carlos and Hospital del Mar in Barcelona. And we followed our patients with IVL. We did an angiogram in patients that had been treated with IVL at more than 1 year follow-up. And in suitable patients, we also investigated them with OCT. This was analyzed in a core lab with QCA baseline and follow-up, and also OCT analysis. And the objective was really to try to understand the long-term angiographic result. We have clinical results, but there is no angiographic results data out yet. Also to understand the changes in the minimum stent area that we see after the procedure. Does this change at follow-up? Do these stents, for example, have recoil? How do the fractures heal? And this is an important question also to evaluate the patterns of vessel healing after IVL treatment. And again, this will be presented by Angela McInerney, one of our fellows that is just finishing now in Madrid, on this same session on Friday. So you will have the two presentations there. But I'm going to show you one of the cases from this angiographic follow-up, because I think it's interesting. This is a 70-year-old male. You can see it's a complex patient with a chronic inferior STEMI, no viability, depressed ejection fraction. He had anterior hypokinesia, and you can see that he had this very calcified lesion in the LAD and an occlusion, a chronic occlusion of the RCA. He presented with heart failure in the context of atrial fibrillation, and in the heart team discussion, he was referred for PCI to the LAD. So once you see this type of lesions with this amount of calcification, we have also there a very important septal that is providing all the collaterals to the right. So you really need to understand exactly which segment you need to treat and how to treat this calcium. So I'm going to show you the baseline OCT pullback, and you will immediately see the amount of calcification that is huge all along this segment, but still we have good lumen. We are approaching now an area where the lumen is decreasing. You will see some funny images there that we will explain, probably corresponding to some areas of chronic plaque ruptures. And you have seen also a significant amount of calcium at the distal part. So if we focus in some of the pictures, you can see here, this is the distal area where we have this very significant calcium. You can see 230 degrees of calcium, very thick, 0.77. We have this area where probably this corresponds to a chronic plaque rupture that the patient had at this level. You can see the membrane that is broken there. And you can see here, again, a lot of calcium, more than 180, very thick, 1.5 millimeters of thickness. This is the proximal area, again, circular calcification, but with lumen at this point. So based on that, we thought that actually shockwave was a very good strategy in this case to treat the calcium and also avoid risk of complications in a patient where we have also a chronic occlusion of the right that is depending on this vessel. So you can see there, this is the IVL balloon working. We applied in this case 70 pulses, and these are the images after the treatment. So you can really appreciate a lot of fractures. You are very familiar, I think, at the moment already with this time of very linear fractures. You can see some dissection also, but especially you can see how the calcium is broken. These very clear linear fractures generated by the calcium, generated by the therapy in the calcium. So you can see, again, more breaks there in the calcium. This is a very clear image. It goes very well with what James was explaining about what is the mechanism in the calcium. This is the proximal part, actually, in an area where the lumen is quite big, an area that we were not planning actually to cover with the stent. So this case was treated with a DES 3.0 and a POT in the proximal part with a 3.5. And this is the result after the stent. So you can appreciate that even in a case with a very severe calcification, we have a pretty good result immediately after stenting. And you can see that the expansion is pretty good all along the vessel. There is some degree of malapposition in the proximal part that is basically related with this irregular shape of the lumen that sometimes cannot be followed by the shape of the stent. But you can really see that the expansion was very good. And you can see actually in the distal part is 100%. This is an area where the stent looks a bit more eccentric, but it's still very good areas. These are the aspect of the fractures after stenting. Basically, they open with when you implant the stent. And these are some fractures of the proximal edge that were not covered by the stent. This is the area exactly of the septal. We didn't want to cover the septal. We didn't want to jail the septal that was providing collaterals. So this is exactly the region of the septal. So this patient was included in the angiographic follow-up, and this is the angio follow-up at 2 years. The patient was asymptomatic. He came for the study, and you can see here the result. You can see the angiogram that looks actually pretty good, but I'm going to show you also the OCT images, where you can appreciate how the vessel has healed after this treatment with IVL at follow-up. And you can clearly see that the stent looks good. There is no late recoil or late lumen loss area, no areas of significant restenosis. So if we compare now some images post-stent and follow-up, this is the distal edge. You can see how the stent is now covered by a normal layer of tissue, normal appearance of a drug-eluting stent, nothing really indicating that the IVL treatment generates, for example, some effect on the healing on the vessel. Same here. This is in this area where the stent looked a bit more eccentric, that has healed properly. This is the area of the septal. You remember there was a fracture there that we didn't cover. You can see that it has healed here. Follow-up is filled with fibrotic tissue and is healed. And the same here in this proximal part, where there was this very superficial calcium. You can see now that there is kind of a layer of fibrotic tissue that is covering the calcium and how the fractures are healed. So just as messages from this presentation, IVL has shown sustained low rates of clinical events at 1 year. The OCT studies have demonstrated consistent results regarding expansion in different types of calcium morphologies. The relation of these morphologies with clinical follow-up is something that will be further presented in this Congress in another presentation. And I wanted just to give you a hint of this initial data suggesting sustained stent expansion and adequate vessel healing at long-term follow-up after IVL treatment. Thank you for your attention.
Thank you, Nieves. Thank you very much, Nicolas. I guess there are many questions.
Yeah, a lot of questions. A lot of questions about the use of IVL in underexpanded stents in your experience. I mean...
I think what was said before is probably is not the indication or approved indication by the company, or not what it was designed for, but clearly it works in underexpanded
We will
stents.
make this point clear. I mean, in the instructions for use, when you open the IVL, it is written that you should not do that. But it's not because it does not work. It's not because it is dangerous. It's just a caution that the company has, because, you know, when you implant a stent, there is a polymer and there is a drug, and we don't have information whether this damage to the polymer will reduce the efficacy of the drug-eluting stent. I think that, as far as I know, this is the only real concern. Having said that, I am sure that the company will review this and get rid of this limitation, because one thing is clear with IVL, is the best and simplest way to expand a stent which is not expanded. So if you are the stent implanter, use IVL until you get rid of the stenosis and put the stent which is well expanded. If it happens, as James said before, that the stent was not implanted but you are just controlling a stent which has failed because it was left like this, you can still try to do it with rotablation. We used to do that, but it's not easy. The mechanism why you will open this stent remains a mystery, because it's not that you are ablating the metal or the plaque behind the metal, but it works, but it may be entrapped. The safest and the most effective way is to do IVL. Even if the company will tell you not to do that, we can hear, for example, from Nieves or from Carlo, they had a lot of experience. I have already published something. Is your question relative to
Thank you for the elegant presentation. My question is about, what about the relation between the pre-IVL imaging predictors like the calcium thickness and the arc of the calcium and the cycles of the IVL we can use? It is operator dependent, or there is a predictors from the pre-imaging?
You mean the sizing of the IVL volume?
I mean the clinical predictors of the calcium thickness and the arc of the calcium and the cycles of the IVL I used.
The cycles, okay.
Yeah. There is any correlation between them?
Not that I'm aware of. I mean, the OCT analysis has been focused very much on the morphologies of the calcium, and I'm not aware of any analysis specifically about how many pulses do you need to apply depending on the type of calcium. As it was said before, I think it depends on the amount of calcium. It also depends on how you see the balloon expanding. Sometimes you start with IVL, and it takes really 80 pulses for the balloon to open. If you apply a number of pulses and you see that your balloon is expanding symmetrically, it's always good to do a couple of angio images and make sure that the balloon is expanding symmetrically, then probably is enough.
Nicolas. Yeah, another question for you. In case you treat a bifurcation with IVL in the main branch, does it increase or not the risk of side branch occlusion? In your experience?
In my experience, it does not, and besides, it has an advantage because you can leave the wire. So it's reassuring that you can leave the wire in the side branch as protection when you treat IVL in the context of a bifurcation.
And there is no risk of, I don't know, increasing the fragility of the jailed wire. You don't harm the jailed wire in the side branch.
We have not experienced any problem. I don't think there is any data in this regard.
Carlo, James, do you want to comment on this controversial issue of dilating the implanted stent?
Well, I think there's the two things I'd say is that you have a known risk, that of an underexpanded stent and how that translates to stent failure and clinical outcomes. And then you have an unknown risk of how you're modifying deleteriously, potentially, the polymer or the stent struts itself. I think it'd be good to know a little bit more about that. I think some bench testing would be helpful to clarify that, and then we could balance that risk a bit differently. What I would say is that if you look at the mechanism of stent failure, it's predominantly stent under expansion. And if you're dealing with acute stent failure, it's very different from chronic stent failure, which we see much more frequently. So if you're dealing with a stent that's coming back sort of 6 months, a year, or whatever down the line, then there's a zero risk that I see to the polymer because the polymer is long gone. So that's the commonest mechanism of stent failure in terms of underexpansion. And that, I don't think it's up for discussion, really. As you said quite correctly, there's significant risks going down the old pathway of larger and larger balloons or rotational atherectomy or laser or any these other data-free zones. I think it'd be good to be a bit more consistent about how we collect that data. And I think there's definitely questions still to answer, but I agree with your assertion that first line IVL is a good place to go, as long as the mechanism for underexpansion is calcific restriction.
$10 million question to our panelists. Are you concerned about the possibility of fracturing the stent because of the energy of IVL?
No.
No. No. No. Carlo?
You show us the money then.
No, I mean, it works differentially on amorphous tissue, and that's not what steel is, for what I understand. I mean, there is one point I wanted to make about underexpanded stents. Everybody says, well, if you see a restenosis and it's somebody else's fault, but sometimes it's our fault, especially in acute coronary syndrome. We predilate with small balloons, we expect the lesion to be very soft, and then once you have implanted the stents, you see that it doesn't expand at all, and you leave these areas of very incomplete expansion, or you use super high pressure balloon taking risks. You have a solution. Use IVL. We may have minimal question marks about what happens to the coating, but honestly, there is no evidence of untoward effects so far. So it's a very efficient device, both for underexpansion for in-stent restenosis and for the rare instances where you didn't do a good job in preparation.
Great. So we move to the next, which is yours, Carlo. Thank you, Nieves. Thank you very much. Carlo will show us the difference in between, gender difference in the treatment of calcified vessels.
So people complain that great technology, but we don't have enough data. Where are the data? And I'm trying to show you some new data specifically about gender, my conflicts of interest. So first of all, women, of course, are rarely treated at a younger age. They have protective hormones, but when you pass the 70s, you have more women than men in your cath labs. And if you look with calcium score at what are the values for women and men, up to 60, you will have a big difference between the two sexes, but above 70, you see numbers are absolutely the same. And obviously, this applies also to severity of calcifications. But in women, I think having the same amount of calcium is even more deleterious because they tend to have smaller arteries. This is an ultrasound study that assessed the left main, and you see there is more than 2 square meter square difference between the left main or a man and a woman. This is a normal artery, but if it was a calcified artery, you are aware of the recent publication of Merana Merana and colleagues on how you achieve a full expansion in stents based on intravascular ultrasound. And one of the parameters that they consider is just the size of the artery. If you have an artery that is smaller than 3.5, this gives an extra point for you to go with a dedicated device. The last point that I want to mention, I don't have quantitative data, but all of you who do angiograms are aware that women tend to have more tortuous arteries, and this means that these arteries are prone to dissections when you go to high pressure and are difficult to be treated with devices like rotational atherectomy. And this is the consequence. More than 6,000 women with no calcium or moderate severe calcifications compared with men, and you see that across all different MACEs, from deaths to stent thrombosis, you have a worse outcome in women compared with men. Specifically, rotational atherectomy, 765 patients, you have more than almost 5% occlusive dissection and more than 2% tamponade due to perforation. And I'm showing you such an example in an 82-year-old lady, one of our first cases when I went back to Florence, diabetic with renal impairment, with peripheral artery disease, was admitted because of effort angina, and the operator found her to have an intermediate branch with subocclusive stenosis, and the large LAD, don't ask me why, started with the intermediate, but using high pressure dilatation, perforated, got a rupture of the artery that felt to have healed with prolonged dilatation and stopping, reverting the heparin, but in fact, I met this patient overnight because she developed tamponade in my ITU, and it's not so easy when you meet a patient the first time puncturing her belly to extract blood. So when I suggested her to do the LAD, she preferred to take her time. Despite all the medicine you see, unfortunately, she developed severe angina and have to come to us. So you see there isn't much left of that intermediate vessel, but there is a very severe lesion, highly calcific, that you see very easily also in the angiogram. In this proximal middle AD, and especially distally, the artery becomes extremely tortuous. So when you look at OCT, you have seen the beautiful images of Nieves before. At that time, we didn't have the ultrasound, the artificial intelligence to automatically measure thickness and arc of calcium, but it's easy to understand that this calcium is thicker than 1.5 millimeter. It's present also in the proximal relatively large lumen, a very severe calcified area, and across the most severe narrowing, you have a 330 degrees of very thick arc of calcium prolonged over a long segment of the vessel with a very small area of 1.08 millimeter square, and the lumen, the vessel size, is also extremely small. Apparently is less than 3 millimeter also in the proximal segment. So you have all the characteristics that lead to a terrible result if you use conventional techniques. At that time, we had to apply to have this system specifically for a patient. We did, and we use a lithotripsy, first a 2.5 balloon distal and then a 3.0 balloon proximal, and you see that there are multiple fractures across these thick layers of calcium with a distal dissection, and at that point we just implanted 2 long stents, 28-33 millimeter, post-dilated, not at crazy pressure, 18 atmospheres, with the result you see. Good circular expansion and excellent apposition, leaving the side branch still nicely open, and you can of course maintain your wire throughout all this process. This was the final result. It's rare that we see a case like the one of Nieves with a follow-up after lithotripsy, because you will see from my data after, target lesion revascularization is 2.5%, target vessel 5%, so hardly ever you need to call this patient for a follow-up because they are well. And in fact, this lady, after almost 4 years, is doing very well, asymptomatic. Since as claudication, I decided anyway to do a stress echo, and you see, is absolutely perfect. All the anterior wall is nicely open, and I expect the artery to be exactly the same as I left 4 years ago. We did publish with Alexandra Lansky the acute results in men versus women from the large 628 meta-analysis that you have recently seen. And this could compare 484 men versus 144 women, being older in age, with more often hypercholesterolemia and renal insufficiency, but a shorter lesion length and smaller vessel diameter. In terms of diameter stenosis, you achieve the same result. Start at around 63% diameter stenosis, and you reduce it post-stenting at around 10%, with similar safety, with the main event being non-Q-wave myocardial infarction defined as greater than 3-fold increase of CK-MB, around 7%, and you see efficacy endpoint, that means success without having one of those events, is 93%. But now I can show you, and that's the first time, in fact, worldwide, thanks to Alexandra Lansky as PI of this sub-study, who will present in a few hours at the SCAI meeting this data, the 1 year data from the combined analysis of CAD3 and CAD4, 106 women against 342 men perfectly followed up, more than 97%. Age around 3 years of difference, older women, 74 versus 71 years, with a reference diameter which is around 0.3 millimeter smaller, slightly shorter lesions of around 3 millimeters. So there are differences between the two sexes, both clinical and angiographic. And I think it's quite amazing to see what is the presence of complications post-procedurally, both after lithotripsy and after stent implantation. Few dissection that are covered and healed after stenting, but no perforation, no abrupt closure, no slow flow, no reflow in all these more than 100 women that we have studied. In hospital MACE, very similar to what has already been published in the full population of the meta-analysis, mainly myocardial infarction, but very few Q waves, very few patients within 1 month in need of a new treatment. And these are the truly new data at 1 year, a very flat curve in terms of new events, with around 5% target vessel revascularization at 1 year, few more myocardial infarction adding to those peri-procedural complications. If you specifically want to look to what happened to the lesion that was calcified lesion that was treated, again, very flat. What happens after the first month, you have a target lesion revascularization of 2.9% in women, and instant thrombosis 0%. So that was my last slide. That allows me, I hope, to conclude that from this meta-analysis we have proved that also in women lithotripsy works extremely well, has an extremely low peri-procedural complication rate, and has to be considered as first-line treatment for calcified plaques and modification of these plaques before stenting, also in women. Thank you.
Thank you, Carlo. I mean, you've shown us results that, there's safety and efficacy results in terms of the treatment. Has that changed your practice? And if you see a woman with a calcified lesion, has this data, has this affected your practice and how you'll manage that calcification?
Thank you for your question. More than the gender, I look after what is the angiographic appearance, and normally women tend to have smaller arteries and very tortuous arteries that are enemies of what are the other dedicated devices we use for calcium, mainly rotational atherectomy. In an extremely severe bend, you know that you will have a wire bias and potentially a risk of perforation, and this is absent with lithotripsy. So irrespective of sex, I think they do qualify more often for the safest technique that we have.
We had some questions as well, just about a lot of this data is on stable patients. Do we have any data in acute coronary syndrome, maybe the presence of thrombus and the use of IVL?
Thank you for your question. As you know, the DISRUPT had stabilized MI or stabilized acute coronary syndromes, but not patients with visible thrombus. However, there are now data, and Margaret McEntergart and James Spratt presented, I think, around 70 patients with acute coronary syndromes, and results are similar. I mean, it's obvious that when you enter with rotational orbital atherectomy, super high speed in thrombus, you just spray this wherever down the artery, while with a gentle balloon dilatation, you can get rid of the segment that doesn't allow you to, for instance, reach the occluded segment and thrombotic occlusion very safely.
Historically, the treatment of females with calcified lesions have yielded worse outcome compared to men. So what you are saying in your conclusion is that this device will equalize the risk? Can I ask Nieves and James if you agree with that in your experience?
Yeah, I think the data is reflecting basically what we see in our day practice. I mean, all the considerations about vessel size, tortuosity, etc., that increases the risk of doing other techniques of plaque modification, such as, for example, rotational atherectomy. Well, they are not that important in this case. Maybe tortuosity in some cases can be relevant because the need of advancing the device, but clearly is a device that does not have a high risk in women, as some other devices have demonstrated.
James, can I? When we were so bad at identifying calcium in angiograms, it's really difficult to even the detection of calcium just with an angiogram. We can be left fooled a lot of the time. How do we know when to go for imaging? What's your threshold? Do you take a balloon, see if it opens, and then go for imaging? Just to try and understand how we fit imaging into this.
Yeah, I think there's two separate questions there. What's your threshold for imaging? I'm never a good person to ask these kind of questions because I do it in every case. I think if you're concerned about calcium and stent expansion, then there's pretty good data to suggest that in the absence of severe angiographic calcium, the risk of stent underexpansion is pretty low. I think Ziad's published a couple of papers kind of reinforcing that. So if you want to get down and dirty and pretend that MSA doesn't matter, you can probably fool yourself best in that arena. What we know with angiograms is that they're insensitive for calcium, but they're quite specific. So if you see calcium on an angiogram, it probably matters. And you shouldn't really do the balloon test because, as we've seen already from the morphology, it's variable. You could be treating eccentric calcium, you could be treating nodular calcium, you could be treating concentric calcium. Why not understand what you're treating and plan your strategy accordingly? That makes a lot more sense to me. Then you can also make your procedure more efficient. You can also make your procedure safer for the patient. And ultimately, you can promise the patient a more durable procedure. So I don't see that as a big sacrifice, 10 minutes of my time to add in a durable outcome for a patient. And I don't really understand why people don't want to do imaging, but I'm happy to help them along that pathway.
Okay, Carlo, let's suppose that your calcified lesion in a woman or makes no more difference. Doesn't matter if it's a female or a male, it's in a saphenous vein graft, degenerated saphenous vein graft. Would you consider IVL or not?
Well, there are really anecdotal reports about it. I do also have maybe 2 cases. I mean, James mentioned that all the hinge points are at risk. The worst are in vein grafts, so there might be terrible calcified, very large calcified nodules. I don't have, again, personal experience of many of those cases. However, there are reports and they seem to show that they do quite well.
I made a question on purpose because if I don't go wrong, I think this is also, let's say, contraindicated. It's not indicated to be used because there is no clinical evidence. But as the use in stent and the expansion, I think we have done several cases, and I think that Margaret McEntagott had published a series. And of course, this is the safest way to try to dilate these fragile veins with a lot of calcium.
They think they have to come, however, with slightly bigger balloon because sometimes they might be extremely large, these vein grafts, especially the ostium, and 4 millimeter might not be enough.
Mm-hmm. And another question from the floor, I mean, any concern on treating left main lesions, or is it a good indication?
Well, I don't know why people think that is risky to keep a balloon for a long time. That's what I heard people saying with to erogate lithotripsy. It's 10 seconds. And in fact, you can even, in between series, go down after the first 5 or 6. So it's really not an issue. So I really no concern, and to be honest, sometimes I see overuse of support devices once this procedure can become much easier with lithotripsy.
Okay, so as the session is conceived, the last 2 minutes are dedicated to to give you a reminder of the conclusions of what we have said. So this is the least, in my opinion, the least interesting part of the session. But I have to put this slide when we see which are the key learnings. IVL safely and effectively modified concentric, eccentric, and nodular calcium, resulting in excellent stent expansion. DISRUPT CAD 3 and 4 at 1 year demonstrated that IVL results are durable with low rates of MACEs and target lesion failure irrespective of the different calcium morphologies. And I think this is very important. Coronary IVL is equally safe and effective in both men and women, and therefore the technology could serve as the primary calcium modification therapy for women. I think these are very important statements. This is a big advantage in our CAD labs in terms of safety and efficacy. I take the chance to communicate with you without the other related sessions during PCR. Next one is tomorrow at midday, and then we have one on Friday at 10:30 if you're interested on following these topics. And then just to remind you that PCR has a dedicated group for the treatment of calcified lesions. This is a group called Euro4C. You can, for free, join the group. This is the website on PCR Online. This is a forum for you to share cases, ask questions, put comments. The group has an editorial board that regularly publish cases every month. So we invited you to join and to share your experience, make questions, and there is a lot of interest in that. With that having said, I really thank you all the participants. It is great to see this packed room, and wish you a very nice evening in Paris.